happy to have, welcome everybody. Really happy to have Dr. James Rutka on our webinar today. This is really a treat for all of us. Dr. Rutka is really a role model for everybody, and he's had an illustrious career that Dr. Maria Noor Al-Huda will formally introduce him, but he's also a personal friend and colleague of mine, and I'm thrilled that he's going to come today and share his experience with brainstem gliomas. This is another great webinar for our series through the tumor section. These will be recorded so they can be viewed later by all our trainees. And I'd like to thank the AANS, Corey Parker, Katie Rico, for really helping us put these webinars together. Maria?
Thank you very much, sir. It's a matter of real honor and joy to welcome Professor James Rutka today, who is being well known by everyone, doesn't need any introduction. And if we start to introduce, he has got so many feathers in his cap right now that it's very hard to do justice. But a few of his very huge achievements include he's the current director of the Order and Sonia Libat Brain Tumor Research Center, and has been the editor-in-chief of the JNS, as we all know him like very well. And he's been awarded several times in his career, including all those wonderful awards neurosurgeon really dreams of. That includes the Cushing's Award, the Cushing Medal, and also the Golden Neuron by the FAANS, and the FAANS also gave him the Medal of Honor. He has been the president of the ANS, and since he was the first editor-in-chief, first Canadian editor-in-chief of the JNS, he was also being awarded as inducted as a member of the Order of Ontario. In 2019, Dr. Rutka received the Cushing Medal, like I have already told you before, and during his career, he penned down several landmarks, milestone papers, and reviewed a lot of, edited and reviewed a lot of papers, as we all know him very, very well. So it's basically a matter of real honor to invite him today, to welcome him today to our webinar series, and he will be delivering a lecture on recent innovations in the management of brainstem tumors. So thank you very, very much for giving us this honor, and for giving your time, no matter how much busy schedule you already have. So please, thank you very much. The podium is all yours.
Great. Well, Maria, thank you very much for the introduction. And Costas, thank you too for hosting these webinars. I'll do anything for the tumor section. I cut my teeth in the tumor section early in my career, and I fondly remember those days leading up to my being the chair of the tumor section many years ago. In fact, the logo you see on the bottom here is one that I was helpful in establishing, along with the artist Ian Sook many years ago. Now he's at Johns Hopkins as a medical illustrator, but great to do this on behalf of the tumor section. And I thought I would choose the topic of recent innovations in the management of brainstem tumors, because a lot has happened in this space of recent. So I'll focus my attention on that. But I do want to mention Costas has been performing in an incredibly important role for us in the Journal of Neurosurgery on the editorial board. And Costas, I hope you're able to sleep at nights and catch your breath time to time with all the work that's involved with the journal. So thank you for your many contributions. Okay, so let's talk about brainstem tumors. So the anatomy is critically important as we talk about these tumors. For many years, these were thought to be inaccessible tumors. But with the advent of better imaging studies, our microneurosurgical approaches, and our understanding of the biology of these tumors, many can go on now to direct surgery. A very simple classification for brainstem tumors is the following. We have midbrain tumors, and they can be focal or tectal tumors. We have the pontine tumors that can be diffuse intrinsic, dorsally exophytic, or focal. And then we have the cervicomedullary tumors as part of the classification system. Let's go from top to bottom. We'll start first with the midbrain, or beginning with the tectal tumors. Here's where they occur in the brainstem, and they essentially occlude the aqueduct of Sylvius. They're typically benign tumors, but they cause hydrocephalus by virtue of the obstruction of the aqueduct, and they're best appreciated on an MRI scan, of course, nowadays. Typically, they have very slow growth, and they're indolent lesions that don't require direct surgery, and CSF diversion is typically all that's required. So as an example of when we don't operate on a brainstem tumor, is a tectal tumor, when it occurs like this. And as I mentioned, CSF diversion in one form or another. Now, probably the best way to do these diversions is with endoscopic third ventriculostomy. Excellent results, of course. And we can biopsy the lesion if it's visible through the third ventricle after we've done the ETV. But here's some great anatomy for you to see as we're embarking on doing an ETV. You can see very nicely demonstrated here the pituitary stalk. You can see the pituitary gland, the dorsum sella here, basilar artery. You see the membrane of the third ventricle. I'll just speed this up a little bit and show you how we use the spreading forceps to grab, to adhere to make a hole in the floor of the third ventricle, and then that allows for free flow of CSF across the third ventricle and the stoma that you create in the context of a blocked aqueduct of Sylvius. Here's an example of a tectal tumor, a little bit bigger, a little bit different than the tumor I just talked to you about, where there's cystic and wall enhancement associated with it. 14-year-old male with Paranode's syndrome and headaches. And we did surgery in this case, and you can see the after surgery MRI scan here. After surgery, the paranodes resolved, and there was no enhancement on the MRI scan. This child did extremely well. Here's the video taken from that particular operation. I'll just speed it up just so you can see we're in the middle of the tumor, draining the cyst, but also in removing the enhancing cyst wall capsule as we go and do this procedure. There are many different approaches to the tectal region illustrated here in this schematic. They can include the occipital transtentorial, infratentorial supracerebellar, where you're facing these veins that, of course, drain into the deep venous sinuses, the straight sinus and the vein of Galen, of course. And then approaches like the ventricular subchoroidal and posterior transcallosal and also subtemporal approach, all are amenable to getting to the tectal region. I also like to draw your attention to the fact that the tectal region is very similar to the pineal region in terms of approaches. And so, as Maria mentioned, as editor of the Journal of Neurosurgery, Focus is one of our journals. It's an online journal where we have video issues as well. And you can see how we're using this particular issue to demonstrate approaches to the pineal region. And I refer all of you to take a look at some of these approaches because they're excellent videos that demonstrate how to get to these deep-seated central regions in the brain. Okay, the next tumor type is the focal midbrain tumors, and these tumors, as shown in the orange, occur in a very important region, the tegmentum of the brainstem, and they typically cause hemiparesis and upper cranial nerve palsies in children. Most of them are going to be low-grade tumors, and many of them are amenable to resection. Here's a case from a few years ago for me, but a 6-year-old female who had left hemiparesis. The tumor is located in the right midbrain. There was also a right third nerve palsy. A biopsy at a different institution showed that this was a low-grade astrocytoma. Child was actually pretty well and alert, but we decided, given the size of the tumor, to operate, and we did an interhemispheric transcallosal resection of this tumor using neuronavigation image guidance. This is what the tumor looked like preoperatively. Here's the immediate postoperative CT scan, again, having approached this through the interhemispheric transcallosal approach. And then many years later, MRI scans showing virtually like no residual of the tumor. The best news for this patient was that the pathology was, and typically is for these tumors, low grade. So this was a pilocytic astrocytoma, and we're learning a lot about these tumors now in terms of their molecular features, many of which are involving the BRAF fusions or mutations and other types of fusion anomalies with these tumors that can make them amenable as well to chemotherapy where there's residual disease after surgery. Okay, another example, I think you'd all agree these are formidable tumors in terms of their location and the risks involved in approaching these tumors. Here's coronal and sagittal images. So this is another focal midbrain tegmental tumor, 10-year-old male. Maybe there was a history of neurofibromatosis, but there definitely was a left hemiparesis. So we used a right transtemporal approach using neuronavigation and neuromonitoring. This proved to be a low-grade glioma. There might have been an inferior quadrant anomaly after surgery, but hemiparesis was actually much improved. This is the immediate post-op. You can see the corridor that we chose, a transtemporal approach using navigation neuromonitoring to resect this tumor. And this child did incredibly well after surgery. After a couple of years, had a small recurrence requiring chemotherapy and has been stable and has really graduated from my care since the chemotherapy has been finished. These also fall into the category at times of something known as thalamopeduncular tumors. So these are tumors that arise from the midbrain in the peduncle, but then extend up into the thalamus. And we now know, as mentioned, these fusion anomalies that can occur and the mutations in some of these tumors. Here's an example of one of those thalamopeduncular tumors with a cyst associated with it. And nowadays, we're using these minimally invasive approaches with tubular retractors to go into the cyst and then debulk the tumor using a cavitron or sonopet. Here's a 12-year-old female with neurofibromatosis, a 3-week history of headaches and left hemiparesis. As often is the case, we get as much in detailed imaging as possible. And you can see here the corticospinal tract, which is wrapped around the tumor, which is in pink here. And the best corridor was essentially cortical, transsulcal, coming into the cyst and then debulking this tumor. And we did this with neuronavigation, the Nicomyriad device, and afterwards, and also neuromonitoring. And afterwards, this child did extremely well. You can see there's almost no trace of tumor left behind after resecting this tumor. And just to show you the physical exam of this child, just about 6 months after surgery, running without any kind of weakness or demonstrated abnormality. So we can approach these tumors in these critical locations, and the children can do extremely well. So one of the innovations, I think, is these minimally invasive approaches. And here's an approach with these tubular retractors that you can see here, and various devices that can be used down the retractors to remove these tumors, and using all our assistance with neural monitoring, neural navigation, of course, with the diffusion tractography, imaging, and everything else that's at our disposal to remove these tumors makes it very safe and minimally invasive for these critical tumors. Another example of a thalamopeduncular tumor in a schematic form here. You can see how close some of these tumors are to the corticospinal tracts. And several publications have arisen from work in this field. So I guess these would be one of the recent innovations with brainstem tumors, minimally invasive approaches. Okay, the next tumor to discuss is the dorsally exophytic brainstem gliomas. These are typically slow growing and indolent tumors located here. The dorsum of the brainstem is the pons. They have long-standing symptoms typically. Cranial nerve palsies can present a little bit later. And then hydrocephalus is also seen by virtue of obstruction at times of the aqueduct of Sylvius, and they're amenable to surgical resection. One of my mentors in neurosurgery, Dr. Harold Hoffman, was the first one to describe these tumors as dorsally exophytic brainstem tumors. At times, surgery is all that's required for them. We try wherever possible not to irradiate these brainstem low-grade gliomas, especially now since we have options with chemotherapy that are available for many of these. We will follow them with serial MRI scans afterwards. Reoperation is possible, but when you do a reoperation on a dorsally exophytic tumor, the anatomy is quite disturbed, and so you have to be very careful that you stay within the boundaries of the tumor and not descend into the brainstem for fear of causing some neurological complications. And as mentioned, most of these are low-grade gliomas. Here's a photograph of Dr. Hoffman, and his first publication on this was either the late 1980s or early 1990s for these particular tumors. all of us want to know from the outset, even before we go into surgery, whether these tumors invade the brainstem. And, I study these MRI scans very carefully before surgery. I look at, in particular, the sagittal MRI, the axial MRI scans to see any evidence of penetration into the brainstem, and that would distinguish them from tumors that arise outside the brainstem that are just filling the fourth ventricle. And so sometimes you can determine in advance, but oftentimes you just have to go to surgery, do the procedure, be very careful with how you approach these tumors, and respect the brainstem, the dorsal aspect of the brainstem, the floor of the fourth ventricle, which is going to be disturbed, so as not to cause neurological deficits. So these are all examples of dorsally exophytic tumors at surgery. They were proven that way. I'm going to show you a case report, a 14-year-old female. Family was Jehovah's Witness, so no blood transfusions possible. Ataxia, headache, papilledema. Posterior fossa craniotomy was done. This was an extremely vascular tumor and arising from the brainstem, and we achieved what I thought was a near total resection. But she had a stormy course after surgery, which I'll describe to you. But here's the tumor before surgery. You can see quite a large tumor post fossa. Yes, it looks like it could fit into the category of dorsally exophytic, but you don't know until you get there. Here's a cap of CSF that's clear, but the attachment point was lower in the pons, as shown here. As a neurosurgeon, if you see blood in the supratentorial ventricular system after a posterior fossa operation, you know that you've had a tough day because blood has gone across the aqueduct. And as I mentioned, this was a very vascular tumor. But after surgery, you can see the nice result that we achieved here. And this child had some issues, and I said stormy postoperative course, including an ophthalmoplegia at first, ataxia that was quite severe, swallowing disturbance, some motor impairment, facial palsy, and so on. But she made actually an excellent recovery. It took her about a year to get back on her feet again. But she graduated, went off to university, again, walking independently, minimal neurological findings over time, did not need a VP shunt. Here's her long-term follow-up image. You can see the tumor has been removed, and I have her permission to show this photo, but she's done extremely well. Has gone off to university, and again, no radiation, no chemotherapy was required, just surgery by itself. Okay, the next category is the focal pontine tumors, and these particular tumors are interesting because they're relatively recently diagnosed and recognized. They aren't filling the whole pons like the diffuse intrinsic pontine glioma, which I'll speak about, but they are filling at least a portion of it, and they tend to be very focal like this. So as mentioned, we're only recently recognizing some of these, and some are going to be amenable to resection, and some maybe not. So a lot of them will turn out to be low grade, but there are definitely some of these that have anaplastic features and are more high grade. But here's some focal pontine tumors that turned out to be pilocytic astrocytoma. And in essence, these are either arising from the pons as a focal basis, or from the, in this case, middle cerebellar peduncle that you can see. But surgery was employed, and a child did extremely well with only surgery by itself. Pilocytic astrocytoma, good news story, decent recovery in terms of neurological function, no radiation. So in these kind of circumstances, we can do these children a favor with these types of focal pontine tumors. Interestingly, many of them may present the lateral aspect of the pons, and so they require approaches to the brainstem that are laterally situated. So typically skull base type of approaches. Navigation is very helpful, and as mentioned, we can use a variety of skull base approaches and avenues to get to these tumors that are often situated here on the lateral aspect of the brainstem itself. Here's an example of one that's presenting on the right side, lateral pons. So a skull base approach in this 7-year-old was thought to be a good one. Short history here, some right facial weakness, and also right limb ataxia. And here's the focal mass shown here. So in this particular case, we did a retrolab pre-sigmoid approach to the brainstem. doing a craniotomy both above and below the transverse and sigmoid junction that you can see here, opening the dura and ligating the inferior petrosal sinus here to get access along and open up the tentorium. And then you can get a beautiful exposure like this to the lateral surface of the pons, the brainstem, exactly where the tumor is situated. Here's what it looks like at the time of surgery. You can see cranial nerve 7 here pointing out. And pre-sigmoid approach is excellent, no brainstem retraction, incision into the brainstem using navigation exactly where the tumor is located and debulking the tumor through a small opening in the brainstem and getting this type of a post-operative result situated. Unfortunately, this tumor turned out to be a anaplastic tumor, so the child went on to get radiation therapy subsequently, and then required to have courses of chemotherapy, but in the end succumbed after about 2 years since the diagnosis. So as mentioned, some of these focal pontine tumors will be low grade, but some definitely will be high grade tumors. So, but it's worthwhile exploring them at surgery and getting biopsy tissue so you can make an informed decision and approach to what to do about these tumors. Okay, so the next tumor type is perhaps our biggest challenge, biggest problem type of tumor, and for which we have almost no treatment options available. A lot of interest now in the research into these tumors, our understanding of their origins in terms of their molecular biology and genetics has increased enormously over the last 5 years. I'll talk a little bit about that. But if any tumor facing a neurosurgeon needs help, this one is one. So it's a tumor confined to the pons. The children typically present with cranial nerve palsies. They're usually young, ages 5 to 7. Hydrocephalus occurs, but not until late in the disease itself. All of these, almost irrespective of the biopsy, if you do a biopsy, results will be anaplastic. Survival, as mentioned, is only about 18 to 24 months at the very most. There's no role for open surgical removal of these tumors because they're intrinsic to all the networks and pathways within the pons. Radiation therapy is the only treatment that is typically offered as standard of care immediately after the diagnosis is made. It provides temporary relief, but as too often is the case, children progress and succumb from their disease in short order. A lot of interesting clinical trials, and I'll speak about some of the innovations, again, the topic of this lecture, that are being done with this particular tumor with some of the centers around the world. So here's a 14-year-old. So this age is a little bit old, a little bit atypical. Somewhat atypical imaging features. Biopsy was recommended as a result. We did an open biopsy, although you could definitely do a stereotactic biopsy. You can see it's coming out the cerebellar peduncle, middle cerebellar peduncle on the right side, occupying almost all, but not completely the entire pons. We did the open biopsy. As you can see, here's the tract for the biopsy here. It was a high-grade glioma, and survival turned out to be 24 months. And there is the post-procedural, post-radiation therapy MRI scan showing some progression. And as mentioned, this child succumbed as a teenager at age 24 months. So standard of care is, as mentioned, focal radiation therapy. Occasionally, and more now, other forms of radiation treatment, such as conformal 3D and also proton beam is being utilized more and more in some centers in the world. There's carbon ion therapy. Not in Canada, I think in very few centers in the United States, but typically, so conventional radiation therapy that's focally administered to the pons at this dose, almost up to 60 gray and 32 fractions. Hyperfractionation therapy has not been shown to be useful. Radiation sensitizers have been used, but again, have not shown meaningful results. And there's been no chemotherapy regimen to date, despite trying a number of chemotherapeutics that has shown useful for this particular tumor, and even high-dose chemotherapy with stem cell rescue has been entertained in the past, but really to no avail. So one question is, do you biopsy these tumors? And the group in France, Paris, showed us that it's reasonably safe to do these tumors with a low complication rate. Here's their paper of 130 pediatric DIPGs where biopsy specimens like these were taken. We recommend a biopsy if you have the ability to perform molecular genetics at a high level, as we do at our institution, because we think we can continue to learn about these tumors through these high resolution genetic analyses, which is what we're doing. But you need to know that there's still a small but not insignificant biopsy risk if you're taking tissue. And we've had, on occasion, hemorrhages as a result of the biopsy in the pons in very rare circumstances. So to get to the some of the innovations with this tumor and some of the genetics that have been uncovered, got a little video here. I hope it'll come across well on your screens. And to set the stage for this video, it was a news piece after we had made a significant discovery on the genetics of these diffuse intrinsic pontine gliomas, all based around a child who had DIPG at a teenager age, so a bit old, a bit unusual. His name was Daniel, and they did all sorts of fundraising events for us based on the studies that you're going to hear about in this video, but also on the family's interest in promoting research for DIPG clinical trials.
New research is out on a deadly form of brain cancer. DIPG affects children and teens, and over 90% of those afflicted die within 18 months of being diagnosed. But as Stephen D'Souza explains, researchers in Toronto say they found a genetic clue about the disease.
This is on our trip to Dominican when we went down after we had just gotten the diagnosis.
Stan and Marisa Bertoya haven't changed their son Daniel's room since his death 6 years ago. At age 16, Daniel was diagnosed with a rare brain tumor and was told he had less than a year to live.
Losing your eyesight, losing your hearing, losing your speech, losing your mobility, basically just devastating to see your son going through that.
His parents scoured the world for help, but found no effective treatment.
We hung on, to every little thing that we could possibly hang on to, but really there was nothing there.
Before his death at age 18, family and friends organized fundraisers, and Daniel had one wish for the money.
He said, Dad, I want it directly to research to help find a cure.
And this big white blob in the middle is the tumor.
Daniel's type of cancer, known as DIPG, is diagnosed in a few hundred young people in North America each year. Located on the brainstem, it's inoperable and chemotherapy is ineffective. But using new technology, researchers at the Hospital for Sick Children discovered cancer genes they hadn't seen before.
The genes mutated in this cancer are completely different than what we see in adults, and so we cannot use the same drugs as what we were using in adults.
That told them they needed new and unique treatments.
We can go to somebody with this diagnosis, and rather than it being a death sentence, maybe there's some hope that some chemotherapies are going to work now.
While that's still years away, after raising more than $500,000 for research, Marisa and Stan are happy to see progress.
To get this little baby step right now, it's just amazing, and I'm hoping that, it'll turn into giant steps one day.
His favorite player.
They say this gives them even more motivation to keep raising money and awareness to help fulfill their son's final wish. Stephen D'Souza, CBC News, Vaughan, Ontario.
Okay, so that was a little bit of news related to our understanding of the molecular biology of these tumors. And here's the papers that came out now, like 10 years ago, but was a significant observation that many of these tumors had mutations in this gene called ACVR1, which is in the bone morphogenetic pathway, among several others, including the H3K27M histone mutations that occur, and 4 of these papers came out simultaneously in Nature Genetics, one of which was from our institution with Cynthia Hawkins, from whom you heard in the video. Same with a group from Boston, from St. Jude, and also from France. So a lot of interest all at once that really put some focus on this particular tumor. So I'm going to leave this on the screen for just a moment, because everything you need to know about DIPG is found on this slide in terms of its clinical pathological features shown here on the right-hand side from a review article that we wrote not too long ago. But the H3K27 mutation is pretty typical in almost all cases of DIPG, and DIPG now is kind of a subset of what's called diffuse midline glioma, or DMGs now. And so here's the H3K27M. You can have P53 mutations, PDGFR alpha, ACVR1 is mentioned. There's a MYC subtype, and then there's a silent pathway that occurs. So all of these things are listed here for your benefit, and hopefully you'll learn everything about DIPG from just studying that slide. So we actually took the notion about observations from DIPG, from the MR images and how patients have presented and so on over time, and came up with a novel treatment strategy. So these are non-enhancing tumors. They're in the pons. We know that the blood-brain barrier is intact, specifically in the brainstem where these tumors are situated. So in many instances, chemotherapy that's too large in size, or most chemotherapeutics that can't go across the blood-brain barrier, will not get into a DIPG, for example. So we asked the question whether using something like MR-guided focused ultrasound, so low frequency focused ultrasound, to break down the blood-brain barrier would enable drugs to cross and have higher concentrations within the tumor center itself. So we did some preclinical work, and we modeled this in animals. And the way that focused ultrasound works at low frequency in the brainstem is that the capillary endothelial cells are basically open by virtue of working on the tight junctions between the endothelial cells in the presence of these blue microbubbles that you see here that are administered just prior to the focused ultrasound treatment. And those bubbles oscillate, they expand in size, causing that temporary breach in the blood-brain barrier, after which drugs, nanoparticles, antibodies, viruses, anything could cross through the blood-brain barrier into the brain itself. And on my title slide, I had this image here, which is a high-throughput drug screen. And we looked at a number of drugs that could treat effectively DIPG cell line models that we had. And these were the drugs that were most efficacious, including doxorubicin. And doxorubicin, or adriamycin, is very interesting. It's not used in brain tumors typically because it doesn't cross the blood-brain barrier. And furthermore, it is associated with very strong results and impact on other tumor types, like soft tissue sarcomas and so on. It's a very effective drug, but we can't use it in the brain because it just won't get to target site. So we showed in our model system that we could increase the concentration of the drug nearly, tenfold by virtue of using the focused ultrasound, and that the surrounding brain, like the brain itself, had almost no concentration of the drug, and then certainly cerebellum had minimal. So that was very encouraging. We published these results as a safety and feasibility study within this animal model. Long story short, we did a lot of work in this field, and we showed eventually that the tumors that were treated in the animals were decreased in terms of their proliferative index and their growth rates. And so this led and spawned a clinical trial that we have now written and are pursuing at the Hospital for Sick Children. And this is the treatment protocol. So patients with DIPG come into hospital. They have their baseline screening. It's 3-cycle therapy. We use blood-brain barrier disruption 3 different times, each spaced apart 1 month. We do the protocol. After the treatments, we then do a variety of testings. During the treatments, we can actually collect blood for biomarker analysis. So it's an ongoing study to see how disrupting the blood-brain barrier in the context of a diffuse intrinsic pontine glioma can open up the blood-brain barrier to deliver biomarkers for us to study in more detail. And again, as mentioned, it's treatment undergoes 3 times and spaced apart each month. And so far, patients that we've treated have tolerated this extremely well. So it was about not quite 2 years ago when we treated our first patient. And here's the MR guided focused ultrasound room. This procedure is performed at the University of Toronto at Sunnybrook Health Sciences Centre, and the patients are then recovered at Sick Kids Hospital. It does require a general anesthetic for the children, at least the younger children. A head frame is placed. There's a water bath diaphragm here that you see that's placed into this water bath that cools the scalp so that the focused ultrasound beams don't cause any skin or thermal injury. Microbubbles are given, and then the drug is administered. Here's what it looked like after the first treatment, and by definition in this study, 50% treatment is given at first. And then the second month, we treat 75% of the pons and tumor. And in the third treatment, we treat 100% of the tumor. And the breakdown of the blood-brain barrier is shown by virtue of gadolinium contrast enhancement, which there isn't any of prior to using the MR-guided focused ultrasound. So there was a bit of a news piece related to this. I'll just play a portion of this so you can hear it. After we treated the first patient in the world with this particular therapy that was a novel therapy for
There's a new medical tool
DIPG.
tonight, giving some hope to families facing the tragedy of a young child with brain cancer.
Health reporter Pauline Chan has more on this technology and where it's being developed.
Yeah, so in the past 50 years, there have been over 150 clinical trials, and they've all failed.
But Dr. James Rutka hopes this time they've found a way to get around the blood-brain barrier and send chemotherapy directly to where it's needed, deep in the brains of children with diffuse intrinsic pontine glioma, or DIPG.
They might have an eye that has turned in, for example. They may be a little bit off balance. They may be stumbling a bit.
Rutka says initial symptoms are subtle, but DIPG is a tumor in the pons, a part of the brain that connects the 2 hemispheres with the brainstem, and it affects everything important: breathing, walking, talking, and more. This cancer generally affects children aged 5 to 7, and survival after diagnosis is usually only about 18 months. But using focused ultrasound, a technique pioneered at Sunnybrook, doctors are hoping to safely open the blood-brain barrier and allow tumor-killing chemotherapy to reach the pons.
Patients in the MRI machine. So this is an MR-guided procedure where we use real-time advanced imaging to really, with pinpoint precision, identify which region of the brain we want to open the blood-brain barrier.
Dr. Neer Lipsman has done this procedure safely before on adults with various medical conditions, but he says it's very different on a small child with a developing brain.
Any intervention needs to be very delicate, very precise, and very specific to this region of the brain.
So this was a world first. This has never been done before. And so we started with a single patient, and the goal is to treat 10 patients in this manner.
It's a really exciting result for us. It's exactly the result that we wanted.
Dr. Rutka says the unidentified child is doing very well after their first session with focused ultrasound and chemotherapy last week. And they're planning to include 9 more children from Canada and other countries in this phase 1 trial. Pauline Chan, CTV News.
Yeah, so that was my colleague, Dr. Neer Lipsman at Sunnybrook Health Sciences Centre, with whom we do this work. We also are in collaboration with Kalervo Hinnanen. He's a biophysicist who actually designed some of the first MR-guided focused ultrasound units in the world. And now the trial is open, and we have centers in Washington, D.C. at the Children's National Hospital, also the Miami Children's Hospital, that are getting into this study along with us. So what's some of the future therapy? Personalized medicine. So doing the biopsy, just returning to those results for a moment, we can find lots of different targets in DIPG. So after radiation therapy, you can imagine using some of these inhibitors in a child, like personalized therapy based on some of the genetic abnormalities that we depict from the biopsy results that are done in children with this particular tumor type. Okay, I'm just going to wrap things up with the last tumor to speak about, which is the cervicomedullary brainstem tumor. I'm showing a photo here of Fred Epstein, who was one of the first to popularize surgery for these tumors that occur in this very important region of the brainstem at the junction between the high cervical spinal cord and the medulla of the brainstem. These children often have lower cranial nerve dysfunction and long tract and cerebellar signs. Here's an image of what one of these tumors look like. Here's the cervicomedullary region here, of course, the cerebellar hemispheres. You can see the swollen cervicomedullary region. We typically do a midline myelotomy for these cases with cautious tumor debulking. Neural monitoring, if it's ever required. This is a perfect case for neural monitoring and how important it is to monitor all the cranial nerves and the motor and sensory pathways as you're doing these procedures. And most children with these tumors will benefit from surgery. Again, as mentioned, to do these operations, you need these children fully wired for protection, meaning that neural monitoring is done looking at all of the cranial nerves that can be monitored. Here's an example of one such tumor in a 14-year-old. Recurrent pneumonia was the presentation, hoarse voice, cranial nerve palsies as shown, and ataxia. Here's what the tumor looked at presentation. At surgery, you can see the cerebellar hemispheres up here. This is a zoomed-in image. You can see a midline myelotomy being performed here, opening up into the tumor. As these are astrocytomas and diffuse, sometimes they're gangliogliomas as well. Rarely would you see an ependymoma, but an ependymoma typically has a very good plane around it, and you look for the plane in a cervicomedullary ependymoma. But here, you do a cautious debulking as shown, and you can get a result like this, where you can do a decent debulking. This turned out to be a ganglioglioma, and many of these have various genetic anomalies, including BRAF mutations, V600E mutations, which may make them candidates for potentially for chemotherapy. You can see the cervical kyphosis that has developed and that many of these children will need afterwards cranial cervical fusions as a result of the instability that is occurring after the surgical procedure. Here's a video showing an approach of a cervicomedullary brainstem tumor. I won't show the whole video, I'll speed it along, but here, opening up, doing neural monitoring the whole time, doing the midline myelotomy, as you can see here, trying to develop a plane, but there isn't really a great plane around these tumors. And then taking a biopsy as shown there, extending the myelotomy downward, doing debulking with the cavitron in this case, opening now higher into the medullary region. At this junction or close to it, we got motor evoked potential changes. So we backed off here and then we went further down caudally and opened up further in the space. You can actually see quite clearly the difference between what's tumor and what's normal, but you have to be extra cautious about going beyond what's safe to remove in these diffusely intrinsic tumors. So that's an example of how these tumors are approached and removed at the time of surgery. Here's a paper from the St. Jude group on cervicomedullary tumors, and their survival curves look like this. Overall survival is actually pretty good. Treatment-free survival is a little bit less, but these children can live a long time, and by that I mean they can live with either minimal residual or residual disease and have subsequent therapies. Here's an example of one of the cases from that series. You can see how a resection was done, how there's a small amount of residual tumor, but a nice overall result. And you want to preserve neurological function in these children as long as possible. And now that we have some targeted chemotherapy that can be used, we're optimistic that we will find even better treatments in the future for some of these children with these cervicomedullary brainstem tumors. So for these particular tumors that occur in this region, surgery can provide stabilization for quite some time. Progression after surgery may require chemo and or occasionally radiation therapy. I mentioned about the instability of the spine and for which occipital cervical fusions may be required. And that now with the targeted chemotherapy and these tumors being not infrequently gangliogliomas and the like, we're coming up with even better treatment plans for these children who have these devastating types of tumors. So here's an example of a brainstem tumor where we decided upfront not to do a major resection, but instead relied on some chemotherapy. So the tumor is here. It's actually in the inferior cerebellar peduncle. So that's a pretty challenging place, has high stakes real estate there. So we did a minimal debulking, as you can see here, and that was followed by chemotherapy. You can see the tumor's actually shrunk down on chemotherapy. And this child, after rounds of chemotherapy, graduated from Sick Kids Hospital, went off to undergrad university, then went off to become a medical student and is now a practicing physician in the province of Ontario. So, and her basically tumor has been stabilized completely and has almost vanished completely on any imaging study that's been done afterwards. Okay, to wrap things up, I mentioned at the very beginning, these tumors can be classified into different types of brainstem tumors according to location. Interestingly, whereas it used to be thought that these tumors could not be approached surgically, I've given you some examples of how, in fact, surgery plays a major role for many of these brainstem tumors. There have been a lot of innovations in the approaches to these tumors over time. I showed minimally invasive surgery, some novel approaches with our understanding of the genetics, use of MR-guided focused ultrasound, the fact that gangliogliomas with these BRAF fusion mutations can occur. And so there's a lot of optimism for the treatment of these types of tumors in the future. To do surgery well in these cases, you need to have your best navigation and monitoring people available to assist you at the time of surgery. And I'm really excited about the future of a lot of these different tumor types. And I'm really hopeful and optimistic that we'll make a dent on the very challenging tumor, the DIPG or the diffuse midline gliomas going into the future. So with that, Costas and Maria, I'll wrap it up. I'd be very happy to answer any questions if there are, but a real pleasure to present this to you today.
Thank you, Dr. Rutka. That was a tour de force presentation on DIPG tumors. As you mentioned, there is so much attention for these difficult to treat tumors. You know, we have some new targeted therapies that are coming out, but the focused ultrasound story is quite interesting and fascinating. And there's even some work now where sonodynamic therapy is being explored with 5-ALA. I didn't know if there's, you know, you could comment on that a little bit. You know, we now use 5-ALA for fluorescence guided surgery, but is that something that you see as another potential treatment option for the DIPG type brainstem gliomas?
Yeah, thanks very much, Costas. The group at the DC Children's National Hospital actually have just published their preliminary results using that sonodynamic therapy in 5-ALA in a series of children with DIPG, and they were able to use multiple treatments over time because it's not as involved or as invasive an approach as our focused ultrasound approach using doxorubicin. In other words, it seems to be much better tolerated in terms of the responses in that, as mentioned, children can keep coming back for more and more therapies without the need or the worry about having the requirement for general anesthetic all the time and prolonged treatments while microbubbles are being given, which is what our protocol uses. So it's still very early stage. There are no long-term results yet available. It's a phase 1 study that was just completed. So I imagine that this will spawn further investigations in this arena. I did hear, however, that the actual approach with the 5-ALA has vanished because the drug the company that was making the drug went out of business or something. But there'll be duplicates or other forms of strategies like that. So I think it's an interesting approach with the 5-ALA.
Yeah, wonderful. Maria, did you have a?
Sir, so there's one question in my mind that when we talk about, like, we say that immunotherapy is a new emerging promising option for many tumors, but for the DIPGs, regarding their microenvironment, so how do you think that immunotherapy could be of any benefit in the case of DIPGs?
Yeah, no, thanks. That's a great question. In fact, we are heading in that direction with our next wave of focused ultrasound studies because this was a proof of principle to show that doxorubicin could go across the blood-brain barrier. But you can imagine if dox can make it across the blood-brain barrier, then anything, can. So a virus, antibody, checkpoint inhibitor, T cells, CAR T cells, they can all go across using this technique. So our next wave of therapy and our enthusiasm for trying to harness the energy of the immune system is very high right now. So our next study you'll see will involve a combination of this focused ultrasound approach and bringing elements of the immune system into the brainstem, because these tumors are relatively immune deficient or cold, right? They're cold tumors, not hot tumors when it comes to the immune system. So if we could make it an immune hot environment, an immune rich environment, the microenvironment which you mentioned, then I think this looks pretty exciting for more long lasting results than you can achieve with, dosing chemotherapy at intervals. So that's what you'll see. Keep your eyes open. Those will be our next studies that'll be ongoing.
Thank you very much, sir. We do have a lot of hope with in the presence of researchers and doctors like you and all this dedication. I believe that there will be one day some hope for these patients who are really in a kind of miserable state. And for the doctors, it's quite hard to tell them what the prognosis will be. And I believe that it will be. There's a lot of optimism in there.
Yeah,
Sir, we do have a few.
Yeah.
Please, sir, I believe Professor Costas.
Oh yeah, we have a few questions here. Maybe we can go through.
Yes.
Yeah.
Sure.
Let's see here. One of the questions is with the DIPG treatment trial that you're proposing, that you're performing, are 3 treatments necessary or is additional treatment beneficial? Also, when is the protocol recommended, during radiation or after?
Yeah, thanks very much. Yeah, it's 3 treatments after radiation therapy, because radiation is it's all that we have right now that has shown temporary relief. So it's the standard of care. So we do standard of care, which is radiation, and then following that, we do doxorubicin therapy. We can extend it off protocol to more doses of chemotherapy, but the protocol is essentially 3 doses and then measuring what we get after the 3 doses. But we have had a situation arise where a patient has asked for more treatments, and we essentially said to them that we'd have to go off study with that. So, but yeah, that's a good question, but it definitely has to follow radiation therapy.
So there's also a question from Professor Georgello. He's asking, Dr. Rutka, it's an excellent presentation today. I may have missed the protocol treatment guideline. I think it's the same question. One question regarding the DIP patient. Yeah, it's the same question.
Yeah, we took care of that one. Yeah.
Yeah, you want to go through some of the other ones, Maria?
Most of them are a lot of compliments for you, sir.
Yeah, one question they had here, Jim, was how do you consent and explain the risks of operating on cervicomedullary tumors to patients and their parents, especially given their relative poor survival compared to other high-grade gliomas?
Yeah, so if the question is about cervicomedullary, yeah, the families need to know that these are high risk, right? You're in a very delicate part of not only the brainstem, but the high cervicomedullary region. And to make these operations as safe as possible, yeah, this is where you really need sophisticated, advanced, and experienced neural monitoring professionals. And that's what we have. We have an amazing neural monitoring team at Sick Kids Hospital. So we get alerts all the time. Sometimes we get more alerts than we want, And question is, sometimes you see your motor evoked potentials go down like 50% or more, and then what do you do? So you all know what to do with the steps to take when you start seeing some changes. But I tend to err on the side of making sure that we leave intact motor for sure, more so than, let's say, sensory. We're okay if we're losing some sensory information. We don't like to see that, but I'd accept more sensory loss than, of course, motor loss. But we have such good sophisticated monitoring that we get alerts well before, typically before we run into any kind of trouble in that regard. And as mentioned, these are gangliogliomas often. They can be low-grade gliomas. The molecular genetics are actually pretty nice to know about as well. And so it may offer some suggestions for chemotherapy subsequent to that. And don't forget, in those particular tumors, the spinal instability that can arise requiring spinal occipital cervical fusion type operations.
Okay. Do we have any other questions?
Sir, I think many of these questions have already been answered during the discussion and also during the lecture. So there's just one question regarding any side effects of the MR focused ultrasound trial. Is there? I think I have noticed there's a question over there.
Maybe the difference between
Any complications?
focused ultrasound versus CAR T-cell intrathecal therapy for DIPG. Some of the newer studies coming out, is there a difference between the two?
Yeah, thanks. I'll just mention briefly, and just to reiterate, our study is low frequency ultrasound, not high intensity. So low intensity focused ultrasound with microbubbles that break down the blood-brain barrier. High intensity frequency ultrasound is for lesions, right? For making a lesion in a low-grade glioma or in a hypothalamic hamartoma or other types of really small intrinsic tumors. It's used for creating lesions for functional diseases like essential tremor, and for Parkinson's and so on. So just make sure you understand that difference in the use of MR-guided focused ultrasound. And then secondly, CAR T cells, yes, we would love to begin a study where either CAR T cells or checkpoint inhibitors or other types of immune, like cellular elements, are infused at the time of focused ultrasound to flood the brainstem with immune therapy at the time of opening of the blood-brain barrier, and then maybe use combination therapy with drugs to drive home that rapid and prolonged tumor response, more so than we can achieve with a single agent.
Awesome. Okay. Well, Dr. Rutka, really appreciate everything. And, the talk was excellent. These are going to be stored for others to view at their leisure. And once again, thank you. And thank you, Maria, for all your hard work on this.
Thanks very much, folks. Nice to see everybody. Take care.
Have a great day.